geriatric patient. So historically, there was a group of geriatric doctors and nurse practitioners, pharmacists, and an interprofessional group that got together and said, what are the four, or not the four, what are the basic principles of geriatrics that can be distilled down into a very handy methodology? And that's where they came up with the geriatric 4M's. Now, if you happen to be a little north of us in Canada, here north of Grand Forks, I should say, which is a couple hours away from Canada, they talk about the geriatric 5M's, and that fifth M is medical complexity. And so I think the 4M's really embody or embrace the concept of medical complexity, because when you practice the 4M's as a set, and that's an important point, is that you just can't do what matters in your clinical visit. Rather, you need to do all four of the 4M's with each clinical encounter for it to work properly. So that's an important construct that we need to keep re-emphasizing. And as I was mentioning, for those that may have been eavesdropping about my lecture to the medical students yesterday, I think I reinforced the concept of the geriatric 4M's at least a half dozen times. And so the expectations are is that as these students rotate in family medicine, internal medicine, and maybe even pediatric, quite honestly, when they're dealing with a grandparent as a caregiver, that they apply these 4M's and that they document that both in terms of their 4M assessment and their 4M management or strategy. Okay, if I could have the next slide, please. So the goals today are to just briefly go over the epidemiology of dementia. We want to talk about a three-pronged approach to cognitive impairment, and also discuss some challenges to assessment as well as those interventions. So again, this being an echo format, we want to do the presentation. We're going to have a couple of case studies, and then hopefully we can open this up to a dialogue for questions and answers about either tough cases that you may have encountered or otherwise. Next slide, please. So this is somewhat scary. Dementia, in particular Alzheimer's, is going to increase dramatically over the next couple of decades, and it will probably overtake cardiovascular disease as the most prevalent chronic disease amongst the older adult population. So we know that age is a risk factor for dementia, and it really becomes a question of, well, how do we prevent aging, which may sound silly, but not so much anymore, that there are ways that we can slow the aging process down. And by doing so, we anticipate avoidance of Alzheimer's disease, at least in a certain percentage of the time. What we'll see here is that there's great variation from person to person. And as a result of that, we talk about what's called precision medicine, or patient-centered medicine. Understanding the specifics of your either metabolism or your genetics will make a difference. And so that's, for example, came out, or it has come out in the pandemic, where people with type A blood, for example, seem to be more predisposed to adverse COVID than people with other blood types. Next slide, please. So the three-pronged approach in dementia is fundamentally to prevent it. And there's a lot of research going on to talk about ways that we can prevent dementia. And then once you've identified individuals that have cognitive impairment, how do you best treat it to try to delay its progression? And then finally, when you reach a certain stage where there's no modification of the disease process, and that it's inevitable that you're going to see that individual reach their end of their lifespan, then we talk about palliative and hospice care. Next slide, please. So to focus on prevention, there's a variety of approaches. So it may not come as a surprise that lifestyle in of itself has a very powerful impact. Also, avoidance of chronic conditions, or what we would call tight control or good control of chronic conditions, is also an approach to prevent dementia. As an example, we know that diabetes, type 2 diabetes, that is a predisposition to early dementia. So for individuals that have poorly controlled diabetes, they have a 3 times increased risk for Alzheimer's disease or vascular dementia. So you would then think that perhaps tighter control of the diabetes would be a good goal, and that would be true. But even more importantly, in terms of prevention, we know that if somebody's pre-diabetic, that 85% of those pre-diabetics can be reversed and prevented to get diabetes. So then you would make the assumption that if you had a very strong effort in a preventive manner to identify everybody who's pre-diabetic, then you would have a good opportunity to prevent Alzheimer's disease, right? So it's kind of like the domino effect. You've got diabetes, dementia. So if you push back or eliminate the diabetes, you then really push back, if not eliminate, the dementing problem. And we can talk about the reason why diabetics are predisposed to dementia, but other things that might come up is chronic pain syndromes, right? So somebody that's on chronic opioid therapy, they are predisposed to memory impairment and dementia. I've actually used this as a clinical tool, if you will, for the individuals that come to my clinic over the age of 65 who might be on a bedtime dose of tramadol. And I said, well, you know, that causes dementia. And so my favorite response was from a patient who says, well, we don't need any of that, do we? So she says, I'll just stop taking it. And so it was a thumbs up success, you know, in terms of opioid reduction. And again, you know, it was 1 tablet at bedtime, low dose. And you think, what's the bother? But quite honestly, every little bit counts. And so these are things that we need to consider in terms of preventing chronic conditions right from the get-go. And as you can imagine, this starts off in middle age, not necessarily in the 65 and older group, but it's never too late ever to start any type of primary prevention. And so for the older adult who might have multiple chronic conditions, really working on lifestyle considerations, which are basically diet, exercise, and social cognitive stimulation, those may have increasingly more emphasis, as well as, for example, very tight control of blood pressure. So there's new information from the STRIDE study that shows that if you try to achieve a blood pressure closer to 120 systolic, that you gain 3 extra years of life expectancy, and you avoid a lot of the hypertensive sequelae, you know, such as kidney failure, stroke, and heart attack. So again, there's new information suggesting that not only controlling the disease, but also aggressively controlling the chronic condition may have some added benefits. And then the final point that I want to make here is the reversal of aging. And so you're going to see geriatric programs become much like hem-onc programs, and in a sense that as the oncologists dispense chemotherapeutic agents, anti-cancer agents, geriatricians will be prescribing either intravenous or oral pills to reverse the aging process. And that's all based on the discovery that there's a type of cell that accumulates as we age. It's called the senescent cell. And that cell, by the way, is the one that produces all these inflammatory markers. And that's why we get all these aches and pains generally. is that these senescent cells are just setting out beacons, saying, your body's under attack. It's like an autoimmune response, not quite, but similar. And that's why we're feeling a lot of fatigue and aches and pains as we get older. Next slide, please. So I want to cover some basic research that we're doing at the University of North Dakota. I mean, there's a lot of basic research. It would take hours to talk about that, but I just wanted to kind of bring everybody up to date as to what we're doing locally, in Grand Forks. So next slide, please. So there's a lot of focus on stress responses, and so there's a lot of reasons to think that an abnormal stress response is contributing to the either onset or the continuation of Alzheimer's dementia. As you all know, amyloid accumulates, neurofibrillary tangles accumulate, and all these are basically stressed proteins. They're all damaged proteins, and they initiate a response to the within the brain that involves white blood cells, inflammatory responses called the stress response. And once that stress response gets turned on, it may not shut off properly, and so that may be part of the problem with Alzheimer's. In addition to the brain not being able to protect itself adequately, so there's both a ongoing sustained response that shuts a lot of things down, and then also the inability to protect against cell death from all these toxins. Next slide, please. So just some new information. This actually, I slipped this slide in here just because it's part of the stress response. It's actually from an investigator from University of California, San Francisco. But he discovered the brakes are on. So once you get the stress response that you see on the left, that this factor called EIF2, which is involved in protein synthesis, gets inactivated and you can't produce more proteins. This is actually a well-known response. And he discovered a molecule called ISRIB, I call it ISRIB, that reactivates this factor and allows the protein synthesis to continue. And he's found great success in a brain trauma model of using this protein that he's developed to reactivate the protein machinery in the damaged brain. And so there's great interest in this for also Alzheimer's and post-stroke patients. Next slide, please. So this is actually some of the research from our geriatrics lab. And again, it's a stress response looking at this factor that you can see in the middle there called HSF1. It's called heat shock factor 1. And it's a protein that binds to the DNA and helps produce additional heat shock proteins, which are protective. And you can see that the response is regulated by both negatively by the red P's, those are phosphorylation of amino acids that downregulate the response, and then the green P represents a green light, that the factor should move forward. And one of the observations that we made is that A circle there, which is the an acetylated carbon group that is defective with aging. And so we know that a lot of this heat shock factor protein accumulates with age with this acetylated form, and it becomes inactive. So even if you are under stress, you can't really produce enough heat shock proteins to respond to that stress. And that's one of the reasons why as we age, the brain cells are less protected from damage. And so you can imagine things like COVID, which affects the brain, might not be such a good thing for older people to get. And I also want to point out there was a new study that came out that people who have regular vaccinations don't get Alzheimer's disease. So I'm telling all my patients, for those that are reluctant to get the COVID vaccine, I said, well, you know that new study, right, that shows that people who get vaccinated don't get Alzheimer's disease. And they go, oh, they roll up their sleeve and they say, maybe I'll go for it. So a little twist in the story there. Next slide. So I just want to point out here, just by that cartoon that I showed you, is that stress factor called heat shock factor 1 declines in a mouse model. So I've proven this in human studies, but this is very dramatic. There's a 50% decline. So an old mouse is a 24-month-old mouse, whereas the 12-month is a more like middle-aged adult. And so you can see that the ability for this protein to bind to the DNA and then activate the DNA to produce message, for the heat shock proteins is declines by 50%. Next slide, please. I wanted to point out that Dr. Colin Combs, who's the head of biomedical research at the medical school, has made a very fascinating discovery that there's, I don't know if it's you are what you eat phenomenology, but he found that he can manipulate the bacteria in the gut and either accelerate or reduce the Alzheimer's model that he sees in mice. Now, again, these are mouse research studies and need to be replicated in the humans, but there's a lot of evidence that your gut has or can have low levels of inflammation. So it's known, for example, that patients with longstanding inflammatory bowel disease, such as Crohn's or ulcerative colitis, have an increased risk for Alzheimer's disease. And this kind of makes sense because even if you don't have those inflammatory bowel diseases, if you have a gut, what we call a gut biome, or the bad bacteria that help stimulate inflammation, that goes up to the brain. And so there are these signals that go back and forth that stimulate this inflammation and this degeneration of tissue. And so there's ongoing studies to show that if you can change the gut biome or create better bacteria, that's a good thing. And so when you think about it, somebody says, "Oh, I've got the sinus problem. Give me antibiotics." And I say, well, might want to think twice about that because theoretically, when you take antibiotics, it wipes out the gut biome and wipes out all the good bacteria. And it takes 7 months for that gut bacteria to regenerate itself after just one course of antibiotic therapy. So if you need antibiotics, you need them, but also there might be a price to pay, in terms of temporarily stimulating these inflammatory bacteria as a consequence of that intervention. So anyways, I just found this very interesting, and certainly we can bring updates as we hear about more discoveries from the Combs lab. Next slide, please. And then finally, Dr. Brown-Borg. So we collaborate with Dr. Brown-Borg, and she studies a type of mouse that's very, very long-lived. And I just wanted to show you that the stress response in these long-lived mice are much higher than what we call the wild type or the normal, usual mouse. And you can see on that graph there that there's like nearly a 3.5-fold increase in the ability of these long-lived mice. DW stands for dwarf, but they're small, but they live long, small and mighty. And they have a really ramped up stress system. So that kind of suggests to us that long-lived older adults have a ramped up stress system and can respond to stress so much better. And that's generally true, by the way, even from a psychological point of view. If you ever interview a 100-year-old or older, you find that they've got a very reflective, live for today type attitude. They're very social. They're fun people to be with. They're very funny. And so I think these are all elements that we need to consider. And the question is, if that's just their natural, predisposition, so be it. But then it's also the question of, well, can you adopt these, live for today, stress-free, psychologically stress-free perspectives and actually extend your own longevity? And that remains to be seen. But certainly there's a lot of powerful research that suggests that maybe stress reduction may be an important element in expanding or extending our active life expectancy. Great. Next slide, please. Well, there's this question of infections and dementia. So there was literally 2 days ago a new report that came out. Again, this is a genetic link, and it's known that this OAS gene, it's called the 2' 5' oligoadenylate synthase. I know it's a mouthful, but it's a viral response gene. It's a gene that we have that when we are exposed to a virus gets activated. And it gets activated by interferon, and so that's that whole, inflammatory cascade. And for sporadic, as opposed to familial Alzheimer's disease, there seems to be an association with this OAS gene. And what came out in this study was that there seems to be, and maybe one of the reasons why Alzheimer's patients die in such high numbers from COVID, is that they discovered that if you express a certain variant or a different version of this OAS gene, it seems to be linked to long COVID syndrome. Now, it turns out that this variant is expressed in 50% of all European descent individuals. So, half the population's at risk for long COVID. Fortunately, we're not seeing that. It's about 25%. It's particularly in women. And 1 out of 4 in the study, and at least in Great Britain, 1 out of 4 women with COVID will experience post-COVID syndrome. Men, maybe more like a 1 out of 10. But if you're an older adult male, you have and have had COVID or survived COVID, you're more likely to have brain fog than similar aged women post-COVID. So, anyways. And there's also an interesting study that shows repetitive infections. Okay, infections. Now, I'm just saying that these are unvaccinated infections, but if they're repetitive, at least again in a preclinical model, that it shortens the lifespan of the animal that they study. So there's additional evidence, for vaccination that may actually enhance longevity. So some really intriguing studies that are coming out. And I just wanted to point out these different disorders that are being studied. There's a lot of anxiety, again, the relationship to dementia or the acceleration of dementia post-COVID, and a variety of other, Parkinson's. So it's actually been pretty well established that people who had influenza earlier in their life have a higher risk of Parkinsonianism. And so these infections have really long gaps between the association with a lot of these neurologic, neurodegenerative disorders. Okay, next slide, please. So we want to consider the assessment part of cognition, right? And so part of the 4M's specifies that we do some type of cognitive screening. And again, if you're doing it with each clinical encounter, I'm not sure it's really necessary to do memory testing if you see a patient 3 times a year. So in our geriatric clinic, we typically see patients 3 to 4 times a year, but we only screen them for memory disorders once during the year, maybe twice if they actually have a memory deficit. Because we want to see after 6 months whether any of our interventions are delaying the progression, or in some cases reversing, and those are rare. So for example, we had a patient with Lewy body dementia, and we switched medications from Aricept, the acetylcholinesterase inhibitor, to rivastigmine, and brought the patient back actually in 4 months. And he did a little bit better than on Aricept with his mental status scoring. So the SLUMS test improved a little bit, but most importantly, his function improved. He was able to sleep. He did not have the nightmares. And again, this is anecdotal and is not going to happen with every patient, but it's a good example of where doing cognitive testing on a regularly scheduled basis with individuals who already have established dementia can be useful from a clinical and certainly from the family and patient's perspective. what you see on the right side here is a brochure that we're creating for the 4M's, and this is intended to be a self-assessment test or an assessment with your caregiver or spouse. So it's basically for community dwelling folks, over the age of 65. And you can see right in the middle there is the mentation and questions, and that represents what's called the Alzheimer's disease 8 questionnaire. The AD8 is the short form for that. And it can be done either by self-assessment, or it can be done by a family member who can check the boxes. And we're hoping that by the self-assessment process, that the people from the community can take these and bring them to their primary care provider and say, I've got these boxes checked here. What does that mean? And hopefully the primary care provider will be savvy enough, because they've listened to presentations like this one, and they'll go, oh yeah, you screened on your 88. We need to do some additional testing. So they then move forward with their additional testing for somebody that might screen positive for cognitive impairment. So that leads to the question of screening in primary care. For those that do primary care, I think it's important to consider the mini-cog, which is probably the best test for screening of cognitive impairment. I didn't have an opportunity to put a picture of a recent mini-cog test I had, but I'll just share with you. It involves the clock draw. And the individual that I was testing, I had already knew that she had dementia, but I wanted to see how she did on the mini-cog. And it was actually quite cute in some respects, because she put the numbers in quadrants. And so she put 1, 2, 3, 4, and then went 5, 6, 7. So she paired each number in quadrants, and then circled the 11 for 10 after 11. And that was her process of thinking about drawing a clock that's 10 after 11. So you find and so she clearly had problems with executive function, right? She couldn't line the numbers up properly. So once you have screening from the primary care clinic, there is opportunities then to make referrals and evaluations. So both geriatrics and neurology clinics are the source of a deeper dive into what type of dementia might be occurring. So we always look for reversible causes, right? Things like hypothyroidism, normal pressure hydrocephalus. We're finding an awful lot of B12 deficiencies, which I don't quite understand. And it's controversial as to whether B12 replenishment reverses the dementia, but it doesn't hurt. It's the kind of medication that, or vitamin that you can't take enough of it. You just pee it out if you have excess. So it's generally not toxic. Next slide, please. Yeah. So so I did put the clock in here. This is not her clock. This is just kind of what I was saying, that she grouped the numbers in quadrants like that. So yeah, I did get the slide slipped in here. And so that's an example of an abnormal clock draw. And at some point down the road here in this series of geriatric echo programs, I want to get a national expert to talk to us about the interpretation of these clock draws. And I'm sending it to Dr. Michael Mercury, who's a UND graduate practicing in Chicago. And I'm hoping to get his wisdom on these different variations of clock drawing. But again, just to emphasize that the mini-cog is the go-to screening test. The AD8 can also be a go-to test. It can be delivered by phone, telehealth, and handing a brochure, to the patient and have them fill out themselves. You can see Noah's Ark here at the bottom with these silhouetted animals marching one by one. This is part of what we call category fluency. And so naming the animals, as many animals as you can within 1 minute, you should be able to achieve 12 or more animals named, whether they be farm animals, jungle, sea, air, whatever. And you'll find that most folks with moderate to advanced dementia can barely get past 2 or 3 animal namings. And a lot of times it's cat, dog, and then they go back to cat. Well, you already said that. Cat, and it's that perseveration, right? And just remember, perseveration sometimes reflects temporal lobe dementia, and that temporal lobe can come from Alzheimer's disease. It can also come from chronic alcoholism, so that's Wernicke-Korsakoff syndrome, where they, constantly repeat themselves. But you can also get that in just garden variety Alzheimer's disease. And I just want to emphasize that Alzheimer's disease is probably 10 diseases. It's we call it Alzheimer's, but there's probably 10 different versions of that. And so that's why it's so important to have this refinement of assessment, so we can really understand where the deficits are, and so we can actually help the older adult with dementing illnesses and their caregivers better cope, knowing where the gaps are. And I've had patients who perfect with their calculations. I mean, we had an accountant who had Alzheimer's dementia, but man, he could do a ledger sheet like there's no tomorrow, like as if he didn't have dementia. So sometimes those indicate not so much Alzheimer's disease, but rather vascular dementia, and they have preserved spheres of cognition, whereas in others they may not. And like in this lady's case, her visual, spatial, and executive functioning, which is more frontal lobe, is just totally messed up, unfortunately. Next slide, please. Yeah, so the deeper dive for us in geriatrics involves primarily the St. Louis University Mental Status Test. Some people might use the MOCA. Nobody's using the mini mental status exam anymore, just because it became proprietary. And I think the MOCA is going to go to extinction also because it's become proprietary. So everybody's pretty much migrated to the St. Louis test. And the St. Louis test, quite honestly, is a little bit more interactive. It's to me, a less threatening type test because it's more conversational. But there's other tests that are coming out also. And I think the deeper dive, the important point here is, as you can see in the picture there, this older adult being tested for neuropsych evaluation. And again, things like the Wechsler Intelligence Quotient test, visual spatial testing, it's very extensive and people get exhausted with it. I'm not sure that everybody can actually do the 2 to 3 hours that's required of it. But it's particularly important for people with higher education. So if you have college graduates or postgraduates with some concerns about loss of executive function, the neuropsych evaluation would be ideal for them. Next slide, please. Yeah, so if you're screened positive for dementia, the first things that should come to mind for the practitioner is to think about caregiver burden. Certainly here in North Dakota, and I appreciate the fact that we have participants from outside of North Dakota. So if you are from outside of North Dakota, you should talk to your Alzheimer's Association and your state representatives to get a free consultation by the Alzheimer's Association on caregiver training. So in North Dakota, it's a state-funded, free one-time consultation to help plan for caregiver burden and issues. And also we provide caregiver training. So our own Dakota Geriatrics program, in collaboration with the Minnesota and North Dakota Alzheimer's Association, has created a 12-sequence series for caregiver training. Excuse me, and it's important to realize that caregiver training reduces caregiver burden. It actually improves outcomes for the Alzheimer's patient. They go in the hospital less times, and just all the metrics that we use for dementia care are ramped up. We really move the needle for acronyms here phenomenally well through caregiver training. Next slide, please. Well, if you can take a guess here, and you may have heard me say this previously, that picture represents turmeric, and it's I promote it in part based on preclinical studies. So 50 milligrams per kilogram of turmeric put in rhesus monkey chow significantly delays the progression of brain changes, that occur, that they observe with normal aging, let alone changes that occur due to neurodegenerative disorders. So there are non-pharmacologic approaches. Research is still out there, so I don't want to over-represent the use of turmeric. But if you do or are interested in that, it needs to be prescribed at a level that's adequate for anti-inflammatory responses. And so that's 1,000 milligrams twice a day. Certainly in dementia management, there are 2 major medications. There's a third one that just got added. I don't want to talk too much about it because the FDA really screwed up in authorizing the monoclonal antibody. The American Geriatric Society does not endorse it whatsoever. In fact, Mass General Hospital, and we'll see maybe in a little bit here, refuses to even dispense the antibody to Alzheimer's patients. And Mass General, by the way, is right next to the company that developed that monoclonal antibody. So you can tell how much friction and antagonism exists for that. Next slide, please. So just talking about the non-pharmacologic interventions, the diet, exercise, and cognition are the mainstay for dementia therapies. Things like reminiscent therapy is a cognitive intervention. Occupational therapists are very good at cognitive training. You can see a nice picture here of these 100-year-old Okinawans who don't get dementia. And part of it is because they're always exercising, they're dancing, they have great social hours. And their social hours consist of green tea, not a martini. Their diet is very vegetarian forward. It's a very Mediterranean style diet, lots of sweet potatoes, as it turns out, and other vegetables, and a smattering of seafood. Next slide, please. Yeah, so the nutritional interventions are basically Mediterranean. There's a new one called the MIND diet, certainly the DASH diet. So if somebody has hypertension, the DASH diet is good. Just simply avoiding extra salt may be an intervention that will have great benefit. So it's important to look at these. Some people are stressing antioxidants, particularly in Parkinson's-like diseases. The antioxidants that are found in pomegranates, cherries, and so forth, any of the berries, are considered to be very useful, in terms of brain protection. So there's definitely nutritional approaches. You may have heard me say this previously, that there was an Italian study that compared regular diets with Mediterranean diets, and over a 5-year period of time, there was greater brain atrophy for those that were on regular diets as opposed to the Mediterranean diet. So the Mediterranean diet, again, seems to protect the brain from atrophic changes, which I think is incredibly important to think about. Next slide, please. So people say ketogenic diet. The evidence is not great. Quite honestly, the cumulative evidence for ketogenic diets as an intervention for Alzheimer's. And I don't know how about you guys, but I eat avocados, but I mean, to basically go on a ketogenic diet with avocados, I mean, you're going to turn into an avocado head or something. I mean, it's just it's just great, crazy. So it's a tough diet to stick to. Next slide, please. So here's one study that recently came out of here this past year. This showed it's a randomized trial for a ketogenic diet. And so you can see here that based upon this cognitive test called the ACE-3, that there was no changes in these Alzheimer's patients. So basically it does not affect their cognition, but maybe importantly, it improves their functionality. So they may be able to do more things on their own or with less supervision. And the quality of life improves too. Next slide. We talked about the gut biome, and I just wanted to reemphasize that some of the anti-inflammatory diets may help promote proper gut biome. If you read the Breslin book on Recode, you'll see some of his ideas for an anti-inflammatory diet. I don't endorse that book. I actually tried to follow his diet and wound up getting gout, so I can't really say that I'm a happy camper with what he says. But you know, if you're interested in reading some alternatives to dietary control of Alzheimer's disease, his book called Recode, you can get it from the library, probably good enough. Next slide, please. Certainly exercise has been proven to slow the progression of Alzheimer's, and it's also preventive, particularly for vascular dementia, right? So if you exercise 30 minutes daily, you reduce your cardiovascular risk factor, you know, such as vascular dementia or these mini strokes by 20%. Now, it turns out a couple of years ago, they found that if you do 90 minutes daily of exercise, that more is actually better. And so now you reduce your vascular events by 40 to 60%. So pretty extraordinary in that regard. I guess the take-home message is that more exercise is better. Okay, next slide, please. I'd mentioned earlier about occupational therapy, being able to provide cognitive therapy. There's other strategies for doing that. There are online games and computer-enhanced cognitive stimuli that you can buy. I don't have any insight as to which of the programs work better than others. I mean, I think the book, you know, if you just get Sudoku or crossword puzzles or number games, connect the dots, those are all probably just as good, quite honestly. Next slide, please. Just want to mention that social therapy is very valuable. Particularly reminiscence therapy helps reduce behavioral problems with Alzheimer's and provides a better sense of well-being. Here at UND, we have Dr. Jeremy Holloway, who's developing what's called TeleECHO, where he's connecting undergraduate and graduate students with older adults, where they tell their stories, and then a book is generated back to the older adult as a legacy. And so we're investigating that as a potential intervention, you know, for delaying the progression of memory disorders. Next slide, please. So it's important people with dementia fall a lot, like 3 times more than people without cognitive impairment. And so we prescribe what's called dual task training. That's where when you walk with the older adult with dementia, and actually this works for people without dementia too, you ask them to count backwards or to do spell words, something that activates the brain while they're exercising. And that forces by activating the brain, by this counting backwards, it forces the spinal column to re-educate itself and to better adapt to core balance. The other things that we normally talk about, you know, for fall prevention is getting rid of the bifocals or the progressives and just wear distance eyewear if you do need distance glasses. You wouldn't believe it or not, that just simple disimpaction of earwax can help with balance. So always looking in the ears. Vitamin D therapy is definitely proven to reduce falls in the nursing home. A little more controversial in the outpatient setting, but again, vitamin D is important anyways because you want to prevent osteoporosis. And then lastly, the issues of trying to avoid antidepressants if possible, as well as antipsychotics. And so what we're seeing a lot of is bedtime trazodone or bedtime mirtazapine because I can't sleep. But nobody's done a very aggressive sleep hygiene intervention with non-pharmacologic approaches. And so people are on all these sleepers and the sleeping medications that increases the risk of falls. So, you know, so if you have problems going to sleep and then you break a hip, I mean, what have you gained, right? You know, so it's really loss of function. So I think we need to approach our whole sleep hygiene a little bit differently, maybe looking at bright light therapy, sticking with melatonin on a more consistent basis, doing deep breathing exercises, all the things that will help with the sleep pattern, and also alcohol avoidance, because if you drink alcohol, it disrupts your biorhythm and you're going to wake up at whatever in the middle of the morning. And the other point is that people with dementia should be empirically treated with pain if they have behavioral issues. And so giving them 2 extra strength Tylenol on a regularly scheduled basis, 2 to 3 times a day, would be a way to try to reduce either their aggressiveness or their agitation that's often associated with these dementing illnesses. Next slide, please. So the approach towards pharmacologic treatments of dementia look at the question of neuroprotection. So a lot of the studies, like Parkinson's, is a dopaminergic deficiency. So they say, let's give more dopamine back. And so too in Alzheimer's, they said there's not a lot of acetylcholine, so maybe we should try to ramp up that neurotransmitter. But there's new information and inclinations to try to deal with antitoxins. And again, these stressed and damaged proteins are emerging as increasingly as a target for therapy. In fact, the monoclonal antibody therapy, the theory behind that is that these monoclonal antibodies attach to the damaged amyloid and help clear it out of the system. And so that's, I mean, the theoretical framework is pretty solid for that, but the efficacy is not so good, quite honestly. Okay, next slide, please. So in that category of neuroprotection falls the memantine. And I tend to prescribe memantine once daily rather than twice daily. And that's particularly true if individuals, if they have reduced renal clearance. So if they have chronic kidney disease level 3 or 4, I just give once a day memantine. But one of the, other than building up neurotransmitters, to amplify neurotransmitters in dementing illnesses, memantine is also thought to have some low-level neuroprotective effects. So theoretically, it helps protect the brain from getting further damage down the road. Next slide, please. The acetylcholinesterase inhibitors are basically those that ramp up the acetylcholine, and again, that's found to be deficient. But again, if you have a lot of neurons that have been destroyed, of course, you're not going to see a lot of neurotransmitters. So typically, if the acetylcholinesterase inhibitors, galantamine, rivastigmine, and Aricept are the top three, if they do have benefit, it's going to be within the first 3 to 6 months of therapy, and it's very transient. So they always claim that about, and I haven't seen the data recently, but generally around 10 to 15% of patients might have some remarkable benefits. So it's certainly worth a try. But I would say 85% of the time, you're going to be pretty disappointed with these medications. Next slide, please. Yeah, so this is the antibody. And it's always a tongue twister for me, so I'm not even going to attempt it. But the idea is that that this is a monoclonal antibody that targets the amyloid protein and pulls it out of the system. You can see the very dramatic results in that PET scan that you can see next door there on this slide compared to the placebo. So if you get rid of the red, that means you're getting rid of the amyloid. But the problem is that there are people with high levels of amyloid that don't have dementia. Okay, so that's number one. So you don't know whether getting rid of the amyloid is going to make any difference in the patient. It's just totally empiric. And this dosing of this particular medication seems to only work in younger onset dementias as opposed to the older adult. So people in their 40s and 50s may benefit from this more than people over the age of 65. And again, it's not endorsed by the American Geriatric Society, so you will not see geriatricians prescribe this medication. Next slide, please. Yeah, so I alluded to this book here. This is Dr. Bresdison, and you can see that he's got this so-called RECODE protocol, reversing cognitive problems, and you can see that the different types of in the lower right-hand column there, that you can see the different types of Alzheimer's that he talks about. There's the inflammatory part, the toxic part, vascular, and so forth. And he has a protocol for treating each of those. Not really proven, and the Alzheimer's Association does not endorse this whatsoever. So again, I just want to bring this up as a resource because it's fairly provocative, and I did a somewhat of a deep dive with this program and rejected it. So next slide, please. Okay, so we can skip that slide. Already covered that. And then I just want to emphasize the idea that we're doing caregiver training. And so the Dakota Geriatrics, in partnership with the Minnesota North Dakota Alzheimer's Association, has created a 12-point curriculum for group visits. And so we're just starting to pilot that here in Fargo and at Sanford. And we'll keep you updated on how that goes. But basically, we're going to do it both with Zoom meetings as well as in-person meetings, where 6 to 10 caregivers will gather, and it's both instructional didactics, but it's also sharing information and best practices. So it's kind of like this ECHO program. It's like, all teach, all learn. It's a similar concept that we're trying to create there. Next slide, please. Okay, so just to summarize, it's vitally important to do your assessments and to have good follow-up with your your cognitive plan that includes non-pharmacologic as well as pharmacologic. But what I'll do is just summarize and say that in the first case, it was a end-stage patient with Parkinson's dementia, and she was on 12 different medications. And by the way, the national average for medications is 12 medications for Alzheimer's patients. That's a lot of medicine. I mean, that's polypharmacy. And assuredly, remember that once you hit 5 medications for an older adult, there's a 100% likelihood that they're going to get medication side effects. So you end up kind of like a dog chasing its tail, trying to figure out what all these side effects are. If somebody comes in with loose bowels or other issues, it's got.
So what kind of research has been done connecting PTSD and dementia?
There's a very strong literature between previous brain trauma and dementia. So that's known. And the other components of PTSD and stress are still, to my knowledge, being investigated. So there's the physical, brain trauma, and then there's the psychological brain trauma. And certainly the evidence that increased stress, psychological stress, is a conduit for dementia over the long haul would be reasonable epidemiologic association.